Okay, so first thing that I have on the list of things to do is carpal tunnel. So definition of carpal tunnel is kind of like a repetitive strain injury compression of a nerve by the carpal ligament and leads to pain and numbness. Commonly associated with computer use, factory work, repetitive wrist action. So kind of like the keyword there is that it's a lot of repetitive action. So what are some manifestations you guys can think about for carpal tunnel? Hopefully none of you have it. We're always on our computers and stuff. Okay, so a lot of pain for sure. How would you guys go into a little bit more detail on the pain? Kind of mentioned it before, but yeah, definitely some numbness and tingling.
Is it joint pain?
Yeah, kind of like the hand, wrist kind of pain. How does it like when does it manifest? With a certain type of action. It usually kind of comes in with a specific action. Yeah, exactly. So it's repetitive action. So that's the thing that's causing it. It's also going to be the thing that's going to cause that pain to come out. It's kind of from a pinching of the nerve. So it's repetitive movement. Um, yeah, that's kind of like the main definition. That's kind of like pain. Um, with that. So bent wrist. Yeah, so that's also like a test that they can do for it. Bending wrist. And we'll talk more about that as well. It can have pain while sleeping too. And this pain is probably like a sharp, yeah, exactly, like a sharp shooting pain. So remember shooting, type of shooting pain is the one of the possible pains for a neuropathic pain. So it's like a wrist nerve pain. And I have a picture here that kind of goes with it. So here you can kind of see what's going on with that. So the nerve is compressed, which kind of is why you get that numbness and tingling again coming from nerve compression. So you can see how that's affecting the area there. Okay. So Lori already mentioned kind of like a potential assessment for it. What are the names of those, or what is the name of the tests that they do, as well as some other assessments you guys can think about? So any assessments that you guys can think about that would be important, and if you guys remember the names of the two tests that they specifically go over, that you could do, yeah, the physical exams with it, that's also good. But so what you're asking. Yeah, it's called the Phalen's test for the wrist bending. And Jackie mentions a nerve conduction study. Yes, that's directly from the PowerPoint. So it makes sense. It goes with the fact that this is a nerve thing, like a nerve damage. The tapping, yeah, the tapping, that one's called Tennell's test. So go over both of those in a little bit, and I'll have a accompanying picture so it's a little bit easier. Again, I just never want you guys to get caught by like the term. So you guys might clearly here you guys know what the test consists of, but like it might not be written in a question as tapping. It might not be written in a question as depending of the wrist, it might be written as Snell's test and it might be written as Phelan's maneuver. So I just don't want people to get answers wrong for something like that. So that's kind of what we're gonna hear. So yeah, so as you guys mentioned, the Phelan's test, that's gonna be the tapping over the nerve. And you're going to get a lot of that tingling, numbness in the thumb and index finger. Makes sense because that's when that nerve is being compressed, that's what's causing those issues. So if you are manually compressing it, you'll be able to reproduce it. And then, like Lori mentioned, there's the Phalanx maneuver, which was able to reproduce that pain, as well as numbness and tingling as well. And I'll kind of show you the pictures that go along with it. So you guys can get a visual representation of it as well. Anything else that you guys can think about for assessment? So someone comes in with carpal tunnel. We mentioned they have this pain. So what is something we want to do to assess the pain, assess what's going on in the wrist and the arm? Hand grips for strength. Okay. I'm sure that could be something you could do. Yeah, what is that? Asking where pain, numbness, what can we kind of in one word, something that we do all the time. Um, starts with a P. We do it all the time when it comes to pain. Yeah, the PQRST. So that's kind of where a lot of this is going to stem from. So you're going to do a good PQRST. So that includes getting things, obviously, like their pain level, how it feels. From that, you might be able to tell that it is in neuropathic pain. They'll tell you it radiates to a certain amount because that's kind of what that shooting pain is. Shooting pain is, if you imagine like a bullet is something that's being shot, it's something that travels. So it's that traveling pain. That's the shooting pain. So you'll be able to um, tell that it's kind of like a neuropathic pain from that. You could ask like what were you doing when it was happening? What's something that precipitates a precipitating factor? So you might find out patient history in terms of um, occupation. Maybe they're like an office worker, they're always on the computer, what kind of hobbies they have where they're always doing repetitive movements. Um, if they have like a previous injury in the area. So all these things that you can do kind of come from the PQRST. Um, so that's like a good thing to think about there. So when it comes to tingling and numbness, what is something else that we can do to assess? Something that, again, this is coming back from early 210, 212 assessments that we can do. So even though here you can tell that it's something related to nerves, what's something else you can do when you hear someone having issues with tingling and numbness? And looking for a physical assessment that you guys are able to assess. Yeah, that's CMS. So again, that's something that you guys can do to see um, their sensation, their mobility, their circulation, because it can be related to something like that. In general, your ortho is very, very heavy. Oh, I saw that, Jennifer. I saw that, Jennifer. I saw that. Good job. I caught that. That's okay. I like it. I like it. I'll give you the emoji right now. Perfect. Yeah. So your CMS, in general, ortho is going to be very heavy on CMS. That's going to be when in doubt, ortho, you want to think about CMS. You want to think about your 6 or 7 Ps, compartment syndrome and things like that. Lori also mentioned assessing areas they can and can't feel. Yeah, that basically goes along with the CMS because that's circulation, mobility, and sensation. when in doubt, ortho is really kind of boggles down to CMS and things like that. All right. So what is your treatment here? Kind of gives it away with this next one coming up. But there's also a few other things that are not just surgical, but you're going to do a surgery. So it's going to be a little bit obvious. But what else can you do? So someone has, because they don't always have to get surgery. It's just a possible thing. So what do we have here? Yes, so we have corticosteroid injections. So that's something that is good for what? What is the corticosteroids good for? Yeah, it's good for inflammation. Great. Yeah, so just kind of also with that in mind that this can be causing inflammation to that nerve area, to that area there that's leading to compression of the nerve. NSAIDs are also going to be medications that are used for pain and inflammation on this one. That's good. And then I'll also ask you guys, and I'll actually I'll get through what everyone said. Someone already said splinting as well. So yes, so remember it's caused by repetitive movement. So if we're splinting, then we're able to immobilize the wrist. So we're preventing um, more of that repetitive movement from happening. But I'll also kind of want to ask, what are you assessing for with your NSAIDs in terms of labs, in terms of it's going to be nephrotoxic, so you want to make sure that the UN, creatinine, urine output, those are doing good. What else can we assess for this? So what's like a common complaint? Yeah, GI bleeding, ulcers, stress ulcers, or GI ulcers, kind of goes with each other. So GI ulcers, bleeding, perfect. What about one with corticosteroids? So what's like a very common thing that corticosteroids can cause? Remember, steroids are very much related to your um, stress release. So when you're stressed out, yeah, your body releases more glucose. So sometimes you'll see corticosteroids, they'll be called glucocorticosteroids. So that kind of gives you that hint that it can cause hyperglycemia. So someone that had like a fracture, even though we're on carpal tunnel now, but like someone in high pain, someone that's had fractures, they might be on corticosteroids, and then this combination of their natural pain, stress, and the medication can cause their blood sugar to be high, even without like diabetes. So this doesn't mean they're gonna get diabetes; it just means they have high blood sugars. Just yeah, it can also cause immunosuppression. So especially overtaking it for a longer period of time, it can cause immunosuppression. And then you guys will learn more about the effects of corticosteroids and cortisol in general in your next MedSearch course and next MedSearch course. But for now, this is probably like above and beyond knowledge for now. But it's good to know for sure. And then a common one that kind of goes with immobilization, that would be rest. So rest, immobilize. And something that you can even go is correct ergonomics. So meaning maybe some of the pain can come from not just from repetitive movement, but also from just um, kind of doing movements incorrectly, like poor positioning on certain things. So just correcting your ergonomics, so your body mechanics, rest, immobilization, and then the inflammation can be managed by your NSAIDs and your steroids. When it's unable to be managed with all of these, then we can consider surgery. So that's going to be more invasive. Uh, Naturally, that's not going to be your first line. But when we are going to be post-op on the surgery, what are some things you might want to look into? Yeah, exactly. So you're not going to stop doing the CMS. So you're still going to be doing vital signs. You're going to be assessing the dressing. Perfect. So vital signs. So all your good post-op things. So assessing the dressing. Um, yeah, your CMS is always going to be, again, when in doubt, when it comes to ortho, CMS is usually the answer. It's usually going to be one of your big things alongside your 6 to 7 Ps. What are the 6 to 7 Ps? Let's see what you guys got on that. Yeah, pallor, pain, paresthesia, pulselessness is a late sign, but it's definitely one of them. Paralysis, another late sign. So we got two missing, two missing. And also worth noting that the pain is especially noted as pain that is not relieved by pain medication. So person could be on hella opioids, but it's um still not doing anything. It's not touching. So these are your 6 Ps for compartment. So yeah, the poikilothermia, that's gonna basically mean a difference in temperature. So that kind of has to go with that inflammation. So one of the things you're going to be doing with ortho is, or just injuries that are unilateral, you're going to be comparing it with their own um, other side. So if it's their right side that has it, then we're going to be comparing it to their left, see if there's a difference in temperature, a difference in sensation, difference in pain, difference in skin color. So they could be pale on one side, not pale on the other. They could be red on one side and not so much on the other. So that's good. That's what that word means. And another one would just be like puffiness, like an extra one. Miss Gonzalez added in that one lecture, but again, it goes with that inflammation. So when it says pulselessness, where is the pulselessness at? Exactly. So it's the distal extremity. So it does not mean they have literally no pulse and you just need to start CPR. It's just referring, it's in the distal extremity. So again, that goes with your CMS as well. All right. So now let's see, this person just got surgery on one of their sites. What is something that's good to do to prevent swelling? Yeah, so pretty much your rice, exactly. So yeah, especially your rice. So that's gonna be rest um, until cleared to do activity. So usually after like 24 hours, you're gonna want to actually move if possible. Ice, compression, and elevation. So elevation is especially going to be really good for keeping swelling, so above the heart if possible. And then lastly, kind of obvious, so I'll just write it down, just education about lifting, ergonomics, so body mechanics and all that stuff about repetitive movement. And then lastly, is this how long are they in the hospital for? Can they go home right after, or do they have to be there for a few days? Yeah, it's the same day surgery. So they might be recovering for a few months, maybe like up to 3 months or so, but they can get out immediately the same day after. And they should be because you want to be early ambulation can be something you want to do. So Kaylin here is typing. What is the long-term expectations with this type of surgery? Yeah, so here, the long-term expectation that she was trying to get at is that we want to have this long-term education. They want to be maintaining their their ergonomics and everything because it can come back even after surgery. It's not like it's like a one and done. You're good for life kind of thing. It can come back. We can still cause inflammation to the area if they keep on doing the same thing. So kind of like a long term is kind of them to take care of that. Take that education to heart. So can long-term carpal tunnel issues cause muscle wasting, like in the thumb? Honestly, I don't know the answer to that. Let's see. Or can you look it up, Kaylin? Yeah, so Kaylin's gonna look that up and I'll get back to you on that. She'll get back to you on that in the chat, I think. But yeah, so possible for them to have scar tissue. So the scar tissue can then, if you keep that repetitive movement, then the inflammation still happens and the scar tissue can then be the one causing that compression. Okay. So then there is bursitis here. Just to be clarified, it says education about lifting, so that'd be like no heavy lifting for of it. So Kaylin says, yes, apparently since you have impaired nerve signals, you can experience weakness in parts of the hands, leading to atrophy. Okay, cool. So new information. Let's see if I have any pictures. I have a picture that just so that the surgery get a better visual on it. Um, think I think because of the way this is set up, kind of like that. So here it's just kind of showing you the incision site. It's kind of like the same thing actually. Now that I look at it, it's just the difference versus like a more invasive versus like an endoscopic one. So there's two types of surgeries, and one of them is more invasive than the other. I guess having just seeing what it looks like should be any. But yeah, any questions on this one? There on out, we're just kind of get a quick overlook of bursitis, and then we'll move on to osteoarthritis and stuff. So, anyone describe bursitis to me? And we'll move on, honestly, from that one. It's just kind of knowing what it is. Yeah, so it's like when the bursa become inflamed. So let's actually define what bursa is. So the bursa are small sacs lined with synovial fluid that are located in bony prominences to prevent friction between bone structures next to the bone. So use these little sacs in between, and they're gonna there to prevent friction. So when they become inflamed, it leads to actually having friction happening. So kind of so inflamed bursae are hard and grind against bone. So with this, you might hear a little like snap crackly sound when you listen to like someone bending their knee, for example. So that's the crepitus, is that kind of snap crackle pop when someone bends their knee. And I don't feel like it was too much of a focus on this one. Okay, so now let's move on to osteoarthritis. So, the definition and etiology. How would you guys describe osteoarthritis, also known as degenerative bone joint disease, or DKD? You might have seen that in the skills lab. Yeah, so exactly. Yeah, you get more bone on bone. Is this something that's going to be systemic, localized? So theory to systemic. So let's talk about ways that or think about your risk factors with that. So some of your risk factors. So we'll talk about systemic versus localized, but first let's actually go through your risk factors and try to work our way backwards on that. So what are some risk factors that come with that are involved in OA? So mention old age. What else? Women typically have a higher risk of osteoarthritis, obesity. What else? Diabetes, the huge. I believe that is true. Not sure which thing. What else is okay? So sports, so people that are athletes. What else? What are some other ones?
Lack of vitamin D.
Sure, kind of goes with like lack of vitamin D and let's say
And
lack of vitamin
calcium.
D and calcium, so they kind of go
Hmm.
together. Sickle cell can be one. What about some jobs that might be at risk for osteoarthritis? Some sure. Kind of how would you kind of cluster them into like one word? Kind of repetitive movement, deliberate. Yeah. How would you cluster them into like one word? How would you describe all those jobs? Blue collar, sure. Like basically like manual labor kind of jobs, right? Yeah. So now let's take a look at a lot of these. So some of these are going to be, things you can't change, like getting older, um, being a woman. You can't, well, whatever, we'll skip that one. Obesity, um, being athletic, so manual labor, lack of vitamin D and calcium, especially these three here. What is that? What do these three in particular have like in common? Like, yes, trauma to the joints is another one. Joint injury and trauma. Now, let's look at these four. What do these kind of have in common? What's happening to the joints when someone is obese? Their joints are sustaining a lot of weight. Yeah, so the stress to the joints. Someone's athletic, they're doing repetitive weight-bearing movements. There's stress to the joints. When someone's doing manual labor, again, just like athletes, are doing a lot of repetitive weight-bearing movements, they're getting stress to the bones. So, if it's mostly based on stress to the joints, do you think this is something that's happening throughout your entire body or to the places that get the most stress? This is actually going to be localized. So this is going to be based on where that stress is happening. So it could be genetics or stuff or stress to bone. So yeah, a lot of time it's unilateral as well. So it's really focused on wear and tear. So they can call this one like a disease of wear and tear. And it's not going to be systemic because it's going to affect the ones you're using the most. So the joints that you're using the most. So a lot of times you see like knees and stuff like that be really affected because they're being used so much that they're being worn down. Yeah, knees and hips are covered. And then that's in comparison to a systemic one where you would see it happening everywhere, even on non-weight bearing joints. And then the one that would be systemic would be rheumatoid arthritis, but that's something you'll go over later. But just wanted to make sure that you guys get the idea that this is a localized wear and tear, stress to the bone and joints. And typically it's like knees and hips are very common. Okay, is that all make sense? Mhm. All right, so what are some of your signs and symptoms you can think of when you have this wear and tear? Do you think it hurts? You think it's there's some swelling going on? Yeah, so kind of makes sense, right? We're not in pain at rest so much as we are in pain with activity, because by doing activity, you're stressing out that joint that's been worn down. So there's going to be pain with activity. Going to be some localized inflammation, again, related to activity again. A lot of time, again, it's based on the fact that you have worn it down. You have taken away that little cushion, so you are rubbing against bone. So it's going to be more painful to move, and it's going to cause temporary inflammation. So kind of like when we talked about bursitis here, we talked about that it helps to it's another the bursae are also like cushions that prevent friction, and this can cause crepitus. So kind of exactly like that, we can also have crepitus, so that little snap crackle pop through movement. Yeah, you can have stiffness in the morning, but it usually yeah. Major part of yeah. So there's gonna be some stiffness in the morning and after long periods of rest. Yeah. So that why is that happening? Kind of think of it like an maybe like gears moving without any oil. That's kind of like your synovial fluid. It's not just a cushion, but it's also kind of like think of it like a lube almost. So in the morning, it hasn't been moved at all. It's really difficult to get it going, so it's going to be stiff. After you move around, it does go the some of that stiffness goes away, but you'll have pain with activity because it's causing a lot of friction to go on. So over time, those gears keep wearing and tearing. There's less cushioning. There's less lube going there. It's just raw gear on gear. So in here it'd be like raw bone on bone. Purpose through range of motion. And then Kaylin here mentions kind of responding to Diane that the inflammation to the joint, like the burning of the joint, warmth to the touch, is mostly present when there's synovitis, meaning like inflammation of that layer of like the
The sac.
yeah, like the little sacs basically,
Inflamed.
or inflamed. Otherwise, yeah, but that doesn't like yeah, Kaylin said here, it doesn't always happen because again, it's not
It's mainly not marked as an
yeah,
inflammatory.
it's mainly not yeah, like Kaylin said, it's not typically marked as a inflammatory like directly inflammatory condition. That would be more like your rheumatoid arthritis rather than your OA. Your OA is purely wear and tear.
Which could inevitably lead to
Yeah.
inflammation in the long run.
Yeah, if you guys can hear her just fine. I can't actually.
Hi.
I can never tell if you guys can hear
Hi guys.
her.
Hello.
Yeah, is that all making sense here? Hmm, yeah. You guys want me to add a little bit more detail to this? Because I think we talked a lot of nuance, but I guess it's maybe not here in the manifestation. But I can talk about the gears thing here.
I thought that was actually a pretty good analogy. It's like in a car without your tool going around and helping you out. Eventually, pieces break off metal shavings.
Mhm.
I mean, that's when you get bone on bone, essentially, when you have the OA, but I thought it was cool.
Okay, so Diane's doing it from like a personal experience. So there might be some.
Oh, she said both of them. My knees,
Mm,
multiple. Oh, you got it on both sides.
yeah.
Not a car guy, but that's all
Mhm.
right.
Yeah, and there's also some like notes and but they're called like the Herpetons, both Bouchard notes. So that's something that can happen. Like you can have like little bone spurs. I'm just gonna post a picture. I don't know if they ask about it, but if they do, the way I remember them is like kind of like based on the alphabet. So my B
It's
is
closer
is
to me.
closer to it's closer to B is closer to me. H is farther away because I don't remember the name. It's just like the one that starts with a B, the one that starts with an H. But that's kind of some things that can happen, kind of like deformity, the dip in the pip. Wait, what's the? Oh yeah, for some reason Herbert's is dip,
Huh.
and other one's pip.
Okay.
Yeah, but this is how I remember it. Just like be closer to me, H farther away. Okay. Then what are some assessments you guys might think about someone that has osteoarthritis? But remember, we're talking about ortho, so when you're in doubt,
Yeah.
yeah, PQRST. What else when you're in doubt? When you're in doubt, yeah, your CMS for sure. And in general, this is again a wear and tear, so range of motion is always good. trying to see if they have Prepidus is fine, like all that stuff here. That's pretty much. Hmm?
ESR.
Oh yeah.
When are you testing ESR and CRP?
Yeah.
When are
So
those tested?
when are those tested here?
I think it's because I went over a question with it.
Oh, I see. That's
I
why.
think both of them were there.
Uh-huh.
Oh, it is on the floor. I stepped on it. For inflammation,
Sure.
so what is it always going to show up with osteoarthritis?
Yeah. So is it always going to show up for osteoarthritis?
Let's
Gonna
clean
be
the
here.
Yeah. It possibly can. What I'm trying to get at is that it occurs with your secondary synovitis. So for the most part, ESR and CRP will be normal if you test it, if the patient just has osteoarthritis, but if they start to develop secondary synovitis where the synovial sac things get inflamed, then you can see an elevated ESR, CRP, inflammation, redness, swelling. Not always.
Yeah. So it's not always
It's
going to be.
good to test.
Yeah, it's something good to test, but it's not always going to be there. Because remember, these inflammatory markers are more of inflammation systemic. They're kind of markers for systemic inflammation, which is not what's happening here because this is a localized event. So when you have synovitis, that's when you'll start having some more inflammatory markers kind of show up. But otherwise, um, your osteoarthritis is purely going to be localized wear and tear, but you can have secondary the synovitis like we talked about before, in which case then you will have the inflammatory markers kind of going off. Yeah. Yeah. So because otherwise having elevated inflammatory markers would be more like a rheumatoid arthritis diagnostic, which is something they always try to rule out one or the other, or like kind of see which one it is between the both of them. But in this case, you guys are only really learning osteoarthritis, so that's just kind of what you have to know for now. Is that it's going to be positive if there is secondary inflammation of the synovial sacs. Otherwise, it's not going to be positive because this is a localized. Okay. All right. So here we have some non-pharmacological and pharmacological management for it. So what are you guys thinking about?
Love that.
I like that a lot. Yeah.
There-
Good. Oh, have to be a closer fit.
Yes. I'm trying to figure out how to yell people.
Pain meds would then go under pharmacological. Yoda. What is Yoda? Oh, I was like, what? Sure, yoga is never bad.
No. The phone never wants to Zell. I don't know how to Zell.
Yeah, weight control.
Topical capsaicin. Capsaicin isn't necessarily. So I was like trying to determine which one that would fall under. Like from phone.
Yeah, so heat or cold. Yeah, so kind of like little extra thing here. Heat is a vasodilator, so it's going to increase inflammation, but it can be good for promoting healing. You do have the synovitis, and you're going to have more long-term inflammation. So here you can see the difference. You're using cold to treat swelling and inflammation. The heat is actually going to cause some amount of inflammation because that means there's more blood flow. That means there's more healing. Talk about weight control, topical capsaicin. I think that's probably goes more in here, but I can see that. Yes. I'll probably put that. Well, that's decent. You want to mention any other meds here? Something. Concept positioning. Yeah, that's gonna be good. So here, pharmacological. We're gonna talk about NSAIDs, but which ones are actually your main drug of choice? Because remember,
It's an inflammatory.
yeah, is this an inherently inflammatory condition? So NSAID COX-2, which is your Celebrex. You can do corticosteroids injections, but again, is this a primarily inflammatory condition? Yeah, your Tylenol, your acetaminophen, that's actually going to be your first line treatment because again, this is not an inherently inflammatory condition, not a systemically inflammatory condition. So Tylenol is actually going to be your first line for the pain. What's your max dosage of Tylenol? Well, for most people, what's the recommended max dose in a day?
3 grams in older adults, 4,000 in regular, or 4 grams in.
Yeah. Right. Although I've been hearing talks that, or I've been hearing that I think it might be changing,
Yeah.
so that it's going to be a lower. So like for normal people, it'll be 3 grams, and then for older adults, it might go down to two. Is that what it
I'm
is?
not sure. It's kind of scattered wherever you
Yeah.
look.
The research is still, I guess, not fully, yeah, still a little inconclusive. Yeah, but that's kind of the idea. And Maha asked pain levels can indicate inflammation, not necessarily. I mean, it kind of depends, I guess, on how long lasting the pain is. So, like, maybe they have long lasting pain, then maybe they're having that secondary inflammation happening from the synovitis. But typically, their pain should go away for the most part after after they refrain from activity. But typically, acetaminophen is going to be your first line. Just keep that in mind. If there is if there is inflammation, then you would use NSAIDs, your COX-2 inhibitors, your corticosteroids, stuff like that. Someone said muscle relaxants, that's another possibility.
I'm gonna go get.
Hmm. Okay. And what are some labs to look out for Tylenol? At your liver labs. What's some physical symptoms you can see in someone that's starting to have liver problems? AST. Awesome. Yeah, so that comes from what's another lab that can be included in liver labs? That kind of ammonia can be one for sure. Your bilirubin is going to be the thing that's causing your jaundice. Ammonia, when someone has high levels of ammonia due to liver failure, what do they kind of present with? Does anyone know that? A little extra, you get extra credit. Yeah, they'll have that's called the hepatic encephalopathy. So confusion from the ammonia buildup. All right, cool. Has anyone had a patient with hepatic encephalopathy? Awesome. Do you know what they were giving them to treat it? You guys remember? If they were being treated at all. Some He didn't have it. Okay, but he had
I
liver.
think Jen's patient, they gave him lactulose. They was trying to get uh,
Yeah, exactly.
him to have diarrhea so he can get it out.
Yeah, my patient had ascites. He had moderate ascites,
Uh-huh.
but he was kind of like his, more importantly, rather than the fluid itself, the problem was for him, it was like coagulopathy. So his plotting values were so off. They gave him like a timeline, like he had only had like 3 months to live because
Oh wow.
his yeah, with his INR was like 4 plus 4.3 or something. His they were all like way off. So he was getting plasma, and they were giving him albumin. Yes, so he did get like an albumin infusion, plasma, platelets, pretty much everything. But it was just maintaining his levels. I mean, wasn't doing anything because his liver, he had liver failure. So yeah, it was pretty scary.
Yeah. So sometimes, yeah, they'll do like someone with liver failure, they can pull ammonia labs. Yeah, they'll have like ascites and stuff. So they might be on like lactulose. Here's another one like rifampin, I think is or rifampicin, something like that. That can also help. So the lactulose is something that can help in a few different ways. Like Rosemary said, it can help to excrete the ammonia in the stool. It also has some effect on the colon, so kind of converts ammonia into a different substance, and makes it less active in the body. So it does it through various different means. But yeah, lactulose as well. Yeah, that's kind of like the main one, just like extra information here, just for fun. Yeah, yeah. I had a patient actually that got paracentesis every 2 days. What? Or is it 2 weeks? No, I think it was every 2 weeks, rather, not every 2 days. Every 2 weeks, but I think yeah, his ascites was really bad, like not even that long, um, like in between. So it probably needed to be done more often.
Don't get liver cancer
Yeah.
or liver failure.
Mm-hmm.
Wow.
Wow.
Double wow.
Wow. Yeah.
That is unfortunate.
Yeah. So your liver has another function, which is managing your clotting factors. So someone with liver failure is also at a higher risk for bleeding. Yeah, just things to keep in mind. All right, so now we're kind of at that review part where we're talking about arthroplasty, the hip precautions. So I kind of just want to talk about the hip precautions. What do you guys remember about that from, I guess, 212, was it?
Yeah.
Uh-huh. You're not crossing. Okay. No abduction. So specifically, we are wanting the toes to be kind of pointing towards the sky. What else? Yeah, we're not going to bend the leg as well. We're also just not going to do general bending past a certain amount.
Okay.
I think it's either one. You want them to be straight. Also, either way you want it to be.
Well, this is adduction. This is abduction. It's just where legs are from the center of the body. Oh, they're both, the toes are both going to be pointing up.
Oh, okay. I guess that's weird. Because I was thinking you meant like with the
Rotational.
feet. Yeah. Okay. Assessing CMS. Nice. No hyperextension. So that would mean, well, yeah, you definitely want to avoid hyperextension.
Pray to God on that one.
Yeah. So I'll kind of write what I have written down here. So let's see. So Theron, you were talking about abduction of the leg. So yeah, that's good. Abduction. Yeah.
There's no abduction.
Yeah, you don't want to do that.
You also don't want to put them too close together.
Yeah. Okay.
I forgot which one was.
That's abduction. There's one that's worse between abduction and adduction.
They usually put an abduction pillow in between a crop. Who was at my session? They were talking about it, that it looked like a little A. Giselle, abduction pillow. She was the one that had the patient, yeah. They keep them abducted to keep them away from the body because you don't want them over itself
Right.
or as close together.
Wouldn't that be an abduction pillow?
No, it keeps the pillows to keep them abducted.
Oh, I see.
Yeah.
I see what you're
Yeah,
saying.
yeah.
Okay. Well, you also don't want them to be too abducted, but the idea is no crossing over. You and in the best case scenario, you want them to just be kind of somewhat straight with the toes facing up. And of course, your CMS, your 6Ps, no crossing the legs, no bending past 90 degrees. They might need to do like isometric exercises, meaning they're just kind of tensing and relaxing. He's changing the font.
Because it was off from the rest.
Oh, was it? It's a different font? Okay, that's fine. So Maha and Lori are talking about early ambulation within the first 6 hours. Yeah, okay. About that. That one's kind
A
of,
lot of the surgeries, they don't want them sitting.
yeah. Early ambulation. Well, just early ambulation, yeah. In general, kind of just like that. Some complications. I don't list them. Dislocation of the hip makes sense. They just did a surgery, so bleeding. If not able to move them and do other stuff. But the reason we want them to ambulate is DBT risk to surgery, so infection risk. Not able to move much, so PI. And then there's a fat embolism. So you guys remember pressure injury?
Oh, pressure.
Oh, I guess I'll write it out. Fat embolism, what would you assess?
Hold up, one of the questions I had. Respiratory, right?
Yeah, kind of like just your respiratory in general. So let's think about respiratory rate, SATO2, favorite breathing, all that stuff. Alrighty. Now the knee arthroplasty. Pretty much similar stuff here. Kind of just wanted to, this is technically review. I just kind of wanted to post what I had and then talk about it. It's a little bit easier. Oh, let's do that. Well, that stuff is, I think, from 212, so it'll be more detailed because that was the first time we had it. Oopsies. Maybe you have to change the font again.
Oh my god, why is there so much?
Just again, this is from my 212, so gonna have maybe some extra stuff, but just BMS 6Ps as always. Patient probably gonna have a drain, so the thing that makes sense with a drain is to document what you see. Gonna make sure they're not bleeding, so neuro kind of goes with the CMS, but neurovascular check, so see that they're not becoming also a level of consciousness. Compartment syndrome, that's why you're getting your 6Ps. You can have ice packs for swelling and pain, but again, you're not putting those directly on the skin. You want a neutral position, kind of facing straight with your toes up. Prevent a hyperextension.
So it checks every time data science is checked. I think that's a pretty solid
Yeah, that kind of goes with the Q4 as well.
good way to group that together. That's clustering care, if you will.
Yeah. Clustering the care.
Pop off, that's clustering care. I love it.
Pain management, multimodal, so opioids with some other stuff, Toralac, Celebrex, gabapentin, the adjuvant stuff. This one's pretty extra. Like that's good. EBT prophylaxis, early ambulation, isometric exercises, all that stuff.
I'm gonna note here, not as common used early ambulation for
Yeah, so
better outcomes overall.
yeah, you'll have better outcomes. On the same, they don't even test them. Yeah. Okay, so then for your management, I don't even know if I wrote anything for management, honestly. I would just rehab, honestly. Have hyperextension of knee,
Reinforcing education.
rehabilitation, what we already talked about there.
Well, potato taste is sad.
Pretty much, just like early ambulation, yeah. Whenever possible. PTOT, yeah, all that stuff. Okay, so now we are on lumbosacral pain. If I'm gonna be honest, wasn't really that high of a focus when we did it, but who knows what could be. Could be different. Yeah, who knows what could be different for your class. So what are some things that can cause this type of pain? Let's see what you guys put down. So it said injury for sure, trauma, injury, trauma. Yeah, kind of poor, but yeah, poor body mechanics kind of goes with it. So one I'm gonna put down is gonna be osteoarthritis, what we talked about prior. Usually that's gonna be in lower joints. So osteoarthritis, obesity. Yeah, a lot of the times when in doubt, obesity is typically can be a cause because you're putting extra strain. Maybe like a herniated disc or something.
Poor body mechanics. Poor body mechanics. Poor body
Uh,
mechanics.
poor body, poor body.
Poor body mechanics. I'm gonna emphasize that one.
Uh,
No. I'm gonna emphasize that one because even during I'm gonna emphasize that one because even for fourth semester I had sim this week and I saw somebody trying to do their interventions and the bed was down and they're leaning over and like, oh, my back hurts watching it. And sometimes we walk around and we see that. So you got one back. If you've heard it before, you know that it continues to stay with you and it'll like the lightest little tweak will set it off. So if you haven't been injured yet, don't get injured. Take care of your back. Take care of your arms. Take care of your legs. Don't end up with lumbosacral pain. That is my TED Talk for the day.
hmm.
Thank you. Thank you.
Awesome. And now what do we have? Yeah,
Take it to heart,
that's good.
please.
Honestly, my body mechanics aren't too good. I always forget to move the bed up.
I've learned my lesson. My back is forever messed up. My
Mm.
back, my arm, my knee. So I kind of don't have a choice.
Yeah.
Yeah,
I
no.
think they heard you. I can't tell.
I don't know. But yeah. Hi, my name's Kaylin. I'm 24 years old and my back is forever screwed up. So yeah, so I have to do proper body mechanics because I've already messed up my back. I've already hurt myself. So you won't catch me doing no trying to lift people up and the bed's at the lowest position or leaning over the side rails when I'm actually trying to do something. Back pain is the worst. It is sometimes debilitating. Don't be in back pain. Don't have lumbosacral pain.
Ah, okay. So manifestations that you guys can imagine that happen with lumbosacral pain. So I'm just gonna write pain. It's in the name. Going over the manifestations. Yeah.
Being the lower back radiating.
Yeah, it can radiate down the leg.
Crunchy down the leg.
Yeah, pretty much. Anesthesia. Yep. I don't know, I'll fill it out actually. Muscular spasm, some weakness. They also mentioned you can have some acute bowel issues, so continence and stuff.
Oh, that thing is real bad.
Yeah, that's if it's really bad, like spinal cord stuff. All right, so let's kind of quickly move on to assessment. So we've been talking about it. So what are like the two things that seem to be very, very prevalent in ortho?
I wonder what it is. 6 Ps.
Yeah, what else? Think about the things that have come up every single time. Yeah, your PQRST, your CMS, and your 6Ps. These are the three things that come up every single time with ortho. Yeah. So another thing I guess they can say is like like back alignment, or like whatever. Scoliosis or the kyphosis or whatever. But some like actual diagnostics would be like X-ray, MRI, CT. Makes sense. And then there's management. So what do you guys think? Someone has lower back pain. Yeah, that can be a pharmacological one. Yeah, kind of like a pillow between the legs and stuff. Or kind of goes with like positioning. Pillow between legs. Sure, kind of like general pain thing. Non-pharmacological pain. So relaxation, whatever. What else? What else has come up consistently when someone has bone joint pain? Yeah, kind of like heat or cold, hot or cold therapy. Depends on the situation. The supports like splints. I can imagine that being something that's good. It's not directly in the notes, but I can definitely see that.
Yeah,
thing.
we have like braces, back
Yeah,
braces.
like braces.
I used to work with a guy at Amazon Fresh. Hi. Um, I used to work with a guy at Amazon Fresh, and he had back pain, and it was like this really like thick back brace he used to wear on his lower back, and it would like it looked like a harness almost. So it had the belt on the lower part of his abdomen surrounding like the lower back. And then it was attached up, like it was on his shoulders too. Like I don't know how to explain that. Like it looked like a tank top, but the top part was all the way down at the bottom.
Huh.
I don't know if that made sense.
Yeah, it was like a harness, huh? It's like pretty much
Basically.
that's what most of them look like, not the harnesses. Huh.
Some of them are just the band.
Huh.
I've seen that are some that are just the band, so
Hmm.
that's why I mentioned it.
Yeah, like back braces, harness. And then something that comes up a lot is like manage obesity. So if someone's overweight, wants to lose weight, exercise.
Obesity.
So um you already mentioned NSAIDs. I think someone mentioned NSAIDs. What else is also good for if someone has like inflammation? We've been talking about this for a long time. So we mentioned steroids, we mentioned NSAIDs, opioids if severe back pain stuff, steroids, yeah, corticosteroids, muscle relaxants, stuff that you notice comes up a lot that keep coming back. So and then for the education, you guys already kind of been mentoring a lot of this. So good improved body mechanics, sleeping on side, pillow, legs. Uh, they say firm mattress, specific footwear, insoles on your shoes, no heels. Okay. And then lastly, I had to have like a section on general ortho surgery. So MIS meaning minimally invasive. Minimally invasive surgery. So what's the things that kind of you guys see a lot when it comes to minimally invasive surgeries? What are some of the educations that kind of keep coming back? What are the things you want to tell the patient to do or not to do? Is this the same day? Is this a multiple day stay? Yeah, it's gonna be a same day surgery. What else? No bending, twisting, lifting. That kind of goes with that. Yeah, sure, I like that one. Side symptoms of infection. When are they moving around? Yeah, kind of like an early ambulation. Pretty much it. It's gonna be a same day early ambulation. You can return to like your full normal activities in a few weeks. Yeah, so they're minimally invasive, so they are not gonna have as much things compared to like an open surgery, for example. You can return in weeks. No streaming BM. Yeah, kind of basically it's just like your general post-op stuff. So like avoid straining is a good one. Um, do IS as well. Like all this stuff that you could do. Just turn cough deep breaths, whatever, your IS and all that stuff. your general post-op thing that you're looking for. Now, what about when you have an open surgery or some assessments you want to do? I'll just try to, you guys know what this, you guys know what's going on. And even here, you still want to do that. You're still going to want to do this. What can you assess for bleeding? What is something that you might see be off if someone's having like an acute bleeding? Yeah, you want to assess it. That's fusion. So that kind of goes with like neuro checks and stuff, blood pressure. Sometimes your blood pressure doesn't tell you everything. So like I was talking to some of you guys with when we were on that mannequin, sometimes your blood pressure doesn't tell you the whole story because your body's compensating all the time. So your blood pressure might be normal even though the person's like bleeding and stuff because of all the compensation. So your BP can be good, but another thing could be like your pulse quality and rate. So all that stuff is good. Neuro checks as well. So yeah, they have weak thready pulses, something's going on. Neuro checks, depending on where the surgery happened, they might have internal bleeding. You might actually be able to see some of that. You will learn more about that later. Okay. Okay, so what about some education? Yeah, sure. Thing. Basically, your typical post-op is still applicable here. Turn cough, deep breathing, splinting, IS usage, infection, all the things you're going to be doing there are going to be important. You might have to do log rolling depending on where it is. Log roll. I think so. Yeah, so that's another one. So patient's ability to they might not if unless they're able to void, they might not even be discharged. So they need to be able to void. What are some things that might have caused them to not be voiding in the first place with an open surgery? A lot of times it's gonna be your anesthesia, your opioids, your sedatives, slows down everything. That includes your ability to pee. So that can happen. So someone fresh out of surgery, fresh out of a procedure when they've gone under, they can have urinary retention, bowel retention, like constipation and stuff. Nerve damage. I could see that being possible because we're dealing with lower back. So that could be possible if like there was something that happened in like the surgery.
I was gonna say if you have your oh hello. I was gonna say if you have nerve damage in your back, that's a point that was gone over a little earlier that you could actually have some incontinence as
Yeah,
opposed to retention.
yeah,
I think it could also have retention, but I believe
yeah.
it's more associated with
It kind of depends though exactly where it is. Like when you guys learn spinal cord injuries at some point, I think there's some like late third semester. They'll go over like specifically what part like can be like what part of the spine can be associated with incontinence versus like hyperactive bladder versus hypoactive bladder and vice versa. But for now, it's just like you can just think about like, oh, it's a possibility that nerve has an impact or the anesthesia has the impact.
So maybe associated earlier.
What do you mean by that? Like maybe if they came in and they already had some like specific like nerve compression or something like that.
No, I was just kind of going with what Kaylin mentioned that with the nerve damage that they may also be starting to be incontinent because they don't have control over their bladder. So
Uh-huh.
yeah, I was just kind of agreeing to what Kaylin was mentioning.
Oh,
So
okay.
kind of made a mental note on that. Thank you.
Mm-hmm. Okay, so here have the complications. So we talked about the fat embolism already. You're gonna wanna let's see if we can get so some things that I have written down are like your early signs, your later signs. Yeah. Yeah, so I have early signs like hypoxemia, so your TSAT-O2, your dyspnea, tachypnea, so someone's gonna have their TSAT-O2 go down, they're gonna be short of breath, and it can come with confusion, acute confusion, chest pain, um, I mentioned dyspnea already. Petechiae, so that's like a last stage sign, like I think petechiae like around the chest area from like internal bleeding in the because the fat embolism a lot of times is basically like a pulmonary embolism.
Yeah, okay, yeah, I was gonna say that's pulmonary edema. I didn't know if that's what you're asking.
Uh-huh.
Yeah, you can see it's down the
Yeah.
chest. Start. Correct it.
DBT, we've already talked about the ECS infection. I guess the one thing we didn't really talk as much about would be the cerebral spinal fluid leak. So let's see what did you guys learn about that? We go into a little bit more detail. Yeah, that's like the main thing. It's like the halo like drainage. And I'm gonna look at a picture of that so you guys can have like a visual representation. Cerebrospinal fluid leak. Cerebrospinal, rather. If we can find a really good one. That's like a phenol thing. Why is this so hard to find?
What did you look at?
Hmm?
What
Oh, there we go. That's probably a good
there's
one.
yeah. I think when I looked it up, I looked up bullseye or something.
Ah,
Bullseye CSF drainage. I think. Do I remember at this point?
that's a good one. That's pretty much that. Okay, let's see. Apart from the PowerPoint.
Or what a real one.
Oh, I think it's like the whole point side up. If there's anything else I have here. So, cerebrospinal fluid, the percent is the halo of the bullseye drainage, pulsing at site, sudden headache. Mm, I think just knowing that should be good enough. I kind of wrote something on drainage, but I'm not really sure. I guess I'll add a few more things here for post-op education on that. You can shower a few days after. Walk daily. PT, back brace, core exercises, pain management, light 5 liter, 5 pound limit initially.
Oh, yeah. The weight limit for
Yeah.
the leg.
I think that's, I don't know why I have this. Actually, no, I know why, because we there's like specific thing on a doctor out on when it comes to the drainage in general. I guess from specifically class, and it can depending on like what kind of drainage we're looking at. But in this case, they said in class, um, not exceed more than 250 ml per 8 hours. So every 8 hours, no more than 250 per 8 hours. Could be a sign of. So if we're looking at their JP drain or whatever, we're going to be assessing that it doesn't hit a certain amount here. So here they want 250 per 8. I've seen different values, but for this one that came from your guys' PowerPoint, probably go with that. Okay. All right. Is there any other questions in regards to ortho? Any that anyone wants to go over? Yeah. So I'm gonna go and give you guys the PDF. And there you go. Yeah, no problem. Recording.